I have to start with a little story. I want to say, it's a privilege to be here. I might be the only non-Roman Catholic here. And the other day I had a medical student rotating with me, and after we'd had a morning in clinic and we'd seen all these Creighton model charts and different reproductive issues we were dealing with, and he was really excited, said, "This is really good stuff. Can you give me a few things to read?" So I gave him a few, sent him a few articles and a link, and I said, "Have you ever read Humana Vitae?" He had told me he was Catholic. He said, "Have you ever read Humana Vitae?" "Well, no, maybe you heard of it." "Well, you should read Humana Vitae." I sent him a link for that. So hopefully that's a seed that takes fruit for him. And I also want to say Paul and I have we have slides to make up for Dr. Bukowski's lack of slides. We sent our presentation to John Berhaney and said, "Which slides should we take out?" And he said, "None of them. They're all good." So we'll see if we can get through them here. If I can get this, remember how this works. This is different than the one you had just. There we go, yeah. Okay, to introduce us a little bit more, Paul doesn't have any disclosures. I have served as a consultant for Swiss Precision Diagnostics. Paul, both of us are family physicians. Both of us trained as Creighton model fertility care. Paul's had some experience in working with healthcare reform and in a more general sense, and he's relatively recently, a few years ago, started a Gianna clinic within a Catholic healthcare system. I've never worked in a Catholic health system, well, for about 6 months, but that's another story. But I've worked in academics most of my career, and started an APRO clinic at the University of Utah in a secular university system. We're both members of the board members of the International Institute for Restorative Reproductive Medicine, and encourage any of you who are interested in research and practice. That's what this organization is all about. So if you have an interest in that, talk to us separately about that. We are going to use the term restorative reproductive medicine. What is that? That's medicine that accords to Catholic principles, medical and surgical evaluation techniques, interventions that restore, promote, or optimize normal reproductive function, female and male, optimize health of the woman, the man, and the child, and to maximize the probability of natural conception when that's the desired outcome. How is that different from NAPR technology? NAPR technology is the same idea with a specific Creighton focus. This is just a broader concept, same concepts. Obviously does not handle gametes outside the body, doesn't include superovulation, and supports the patient's right to understand and cooperatively manage their own fertility. So the question we'd hope to address today is, how can a Catholic health system ensure that the restorative reproductive medicine services that it plans to offer are of the highest possible quality? Why should I be talking about that? I don't work in a Catholic system, but Paul does, and we both have ideas about how do you ensure that these services are of high quality. So we hope those ideas are helpful to you today. Our focus is about quality assurance and evidence-based for quality improvement in clinical outcomes. We're not talking, there are other talks today have been excellent to talk about the ethical issues or financial or legal structures or the surgical components. That's not what we'll be talking about. As I mentioned, NAPR technology is a specific system of restorative reproductive medicine based on the Creighton model fertility care system. Other types that have some published medical support include Sensiplan, that's a German symptothermal system, published some medical applications, and the ovarian monitor is also published. You might say, well, there are some others here I haven't listed, and the reason I haven't listed them is they don't have peer-reviewed publications at this point for the medical applications, and this isn't talking about the natural family planning, this is talking about medical applications. So, and that's not to say there might be some others that be developed and published data, that'd be great. How do you assure the quality of restorative reproductive medicine services? These are the components we came up with that we think are important. Training, mentoring, and peers. And we've heard about the importance of that, of how a peer brings you along and helps you figure out how to apply it in practice. Certification, there's a little bit of that available now, and there may be hopefully more in the future. evidence-based continuing medical education, really important, quality assurance and assessing your outcomes systematically. That also has an accountability component. And then how would that all fit together for a successful program? Paul will talk a little more as we get to that. As you've heard many times today, this is not part of standard medical training to learn about restorative principles in reproductive medicine. Very rarely will it come up in standard medical settings. There are some introductory CME courses. By far the most developed and best one currently, in my opinion, is the Pope Paul VI Institute Medical Consultant course. Some other groups have some weekend courses. There's currently one surgical fellowship at Pope Paul VI Institute. I want to put a plug in that I do have currently funding available for a research fellowship at the University of Utah. And if you know somebody wants to do that, either clinician or non-clinician, please talk to me. In terms of clinicians, didactic training is not sufficient. You can go to several weeks of CME, and you go home, and you have no idea how to get started to put in practice. This was, I think, that's been an experience of everybody I've ever talked to. I've talked to some of you at this meeting today, say, yeah, I went to the EP, but I haven't really figured out how to get it into my practice. You have to go and see somebody doing it. And for me, that was going to the Institute for a while. I went to visit Phil Boyle for a while. Actually, I've had the privilege of visiting a number of you. I visited in NOLTU. And seeing how people actually do it in practice makes the difference. You can't just learn it. But it's just like, would you trust someone who had read the OB/GYN textbook but never did an OB/GYN residency? It doesn't make any sense. It's the same thing here. You can't just read it. You can't just go to a CME course. You have to actually have some experience seeing it in operation. If you try to do it by yourself, you'll probably sink. Now, I say that, I actually am kind of by myself at Utah, but I've had a lot of support visiting other colleagues and staying in touch with them for how, when I have questions, I know who I can talk to. You can't just be completely solo. There are webinars. The IRM does webinars that are really good for CME. There's consulting that Deanna has I think it's a weekly group that I've been in on a couple times, a phone group that does consults. You have to have some kind of some resources to make these connections and discuss the cases and figure out how you're applying these principles. And I've been talking about physicians. This also applies to nurses, medical assistants, other personnel, but I think you could see how those principles could apply beyond just physicians as well. So certification is currently available through the American Academy for Fertility Care Professionals. I'm certified through that organization in NAPRA technology, and that is a good certification. But I think it won't be the final end all in what's available down the road. Potentially, I think some of us would like to see a specialty come out of this. That would be a few years down the road still, I think. We talked about evidence-based CME. I'm going to put a plug in, and I was a past president of the AAFCP, but they do excellent evidence-based CME, as well as the IRM that I'm currently a board member of. Some of those are webinars, some of those are meetings, and there's meetings like this where you get some of those things as well. Now this is one I want to spend a little bit more time on, and this is something, because it's not, I think, routine for all of us. I think a good example of the value of this is Dr. Hilgers and the Pope Paul VI Institute. They have systematically looked at their data for what they do and their outcomes for a long time, and that's where much of their data come from. But I think this is also a general thing coming in medicine generally. I think many of you, or most of you, are probably all aware of this. This is a movement to examine your practice, whatever it is, not whether it's pediatrics, orthopedics, whatever it is, and look at your outcomes systematically and have accountability for that. I want to, and some of the medical certification boards are pushing this, and it's because it has value. You figure out systematically what are your outcomes, what can you do to improve them. some of our efforts to do this with restorative reproductive medicine, one that's concluded is called INEST, one that we want to start is called STORM. So I want to talk about those just a couple minutes, hopefully give you some ideas, and happy to follow up with any of you for further individual discussion. So INEST is a study we did called for the International Network Technology Evaluation and Surveillance of Treatment. We opened enrollment for this in 2006, closed it in January of 2016, ended up in a year later. We have 6 sites in the USA. Paul was one of those, and there are a couple others here. I think I have to stop it. And then we have one in Canada. We have one in Canada, one in UK, and one in Poland. We enrolled 835 couples who were trying to conceive, with a mean age for the women of 34, mean years of trying to conceive of 3.7, and 51% had an outcome of at least one live birth during the study. This is a Kaplan-Meier curve of those who had a live birth, and these results we presented at the ARM, and they're in process to get published fairly soon. We're working on the paper currently. But you can see that those that were more likely to have live birth this is followed for up to 3 years. This is months down here. Get this right. Sorry. I got the right, I get myself on the right button, sorry. Anyway, I will not try to do the pointer, it's not working. I'm not figuring that out. But anyway, you can see that those that had been trying for a shorter amount of time were more likely to have live birth, but even those that had been trying for over 3 years got to about a 50% overall live birth rate. Overall, they had a higher likelihood of success if they had less previous time trying, had a prior pregnancy. There was no significant impact for income, race, clinic site, or women's age. And that, I think, that doesn't mean the women's age doesn't have an impact, but in the range that we had in this study, it didn't come out statistically. STORM is what we would like to get doing in the next few years. We call that surveillance of treatment outcomes, and with the broader term of restorative reproductive medicine, because we want it to be open to anybody who wants to try to improve their outcomes, whether it's NAPRO or something other approach that's restorative. In this we are trying to develop an accountability to the public. And I think there is an analogy here. I think most of you are aware that IVF clinics in the United States and in other countries are required to report their outcomes to a central agency. Now, there are some issues about how they do that, but in principle, these are outcomes that anybody can look up on the website and say, you know, what are the procedures, what are the outcomes. We would like to see, for those who at least would like to participate, similar kind of open outcomes available for restorative reproductive medicine. So the approach here, I was talking about this with Dr. Young yesterday, is instead of going with consenting people into a study, do it on a quality improvement basis, that you just compile the statistics for the whole clinic without having to consent patients into the study. And that's the approach we're looking at. And that gets a more inclusive set of data that's more representative as well. We want to recognize participating practices as it'd be a badge of honor, hopefully, to be part of doing this quality improvement. With sustainability, that's our biggest challenge. How do you do this? So we think that probably you have to end up having a little bit of money to participate to make it sustainable, because our past experience with INEST, for example, was several different vendors over the years that were one that gave us a fair amount of money and then pulled it out after a year, and we had to scramble. So to be dependent on external funding doesn't seem like it's going to be something, if it's going to last over a long period of time. And then inclusiveness in terms of medical approaches, as long as the principles of restorative reproductive medicine are being used. Core data we want to look at are the key things that affect, and again, we're starting with fertility. There are other aspects that are important too that could be developed in the future. We think fertility is a natural starting place. So age of the woman and the man, preceding time, attempting prior treatments, prior births or pregnancy, and then the key interventions and the pregnancy outcomes. We have not started this yet. We need some time. My time is pretty tight these days until we get a little bit of time, money, and resource, which I hope some doors open somehow in the next year or two. We'd like to get this started, but this is a concept. So I guess I'm hoping that inspires you either to do something yourself or to help us get this started. So I can't remember exactly where you're picking up, Paul. Is it one or two more? This is my last slide. Thank you. So to ensure the highest possible quality of our, we talked about good ethics or good medicine, but also the ethics are to produce. We've heard the theme of being the best physician you can be. How can you be the best practice you can be? Offer the best service you can. Well, there's training, like going to the NAPRO training, for example. There's mentoring and peers. There's certification. There's keeping yourself educated with good CME, and then looking at your own outcomes systematically. With that. On the other side will
in case I turn to the mic.
Works.
Wonderful.
And then that's advances up and down as it
Okay. Thank you. Is this working okay where it is? Okay. It sounds noisy though. Okay. Thank you, Mike. So, you've come to the last speaker. Congratulations. Your endurance is important. It has been important. I know what it's like to sit in Dr. Hilger's lectures, but they start at 7 in the morning and finish at 8 o'clock at night. You guys are getting some privilege here. But before your thoughts turn to home and to work, John Brahaney and I wanted to give you one last insight. Thankfully, it's good news. And I'm going to read my intro, and then I'll walk around a little bit. And before we dive into this very complicated slide, I'm sorry I put too much information on it. But before we dive into that, I'm going to read an intro, because my intros could go on for 10 minutes. So I'm going to read it to you, and then we'll dive into the economics of this situation that we've been discussing. So you have heard the theological basis for restorative reproductive medicine, and the marketing, and the surgical skills, and the medical advantages, and success stories, and stories of pioneers and new projects. You have also just heard of training and outcomes reporting. My goal is to help you understand a little bit about economic advantages and the role that restorative reproductive medicine can have in healthcare reform. In a moment, I'd like to ask for a show of hands, and it's going to be about who is here with a role that is related to hospital administration, practice administration, faculty, chief medical officer, IPA, PHO, mission, ministry, research, or policy. If you're connected to those things. Okay, so this conference, I think, in dealing with John in the preparation for this conference is really dealt to you so that you can help guide your healthcare systems and healthcare policies through the tangle of this very complex world in which we find ourselves. The medical people have been here and they've learned a lot. I've learned a lot even though I've been in this for 32 years. I was one of the first family physicians that Dr. Hilgers trained. Now, far be it from me to propose that a doctor without an MBA is here to teach you economics. But I have surrounded myself with smart people for decades. And I've learned from a certificate course at Brandeis on healthcare reform. And I have been in skyscraper boardrooms with insurance execs in my role as medical director for the most innovative ACO in the country, Accountable Care Organization. So I have some insights for you. Let's start with two rhetorical questions. What would a healthcare reformer say about restorative reproductive medicine, naprotechnology, and fertility care? I have some quotes for you at the end. And then second rhetorical question is, how would a Catholic health system pay for restorative reproductive medicine? In the US, I'll tell you a story now about healthcare reform. In Massachusetts and the US, I'm mainly going to refer to Massachusetts because that's where my practice was for 30 years. It used to be filled with private practices, Massachusetts was. This is back in the 1970s, filled with private practices. In fact, there were laws against hospitals taking on doctors and practices. They were called the Stark laws. But then, efficiencies and management complexities and concepts of team care came into play. And we saw the cost of medical care going up and third world nations having better outcomes than the United States. At that point, they started to allow providers to be taken into systems. And these systems then began to swallow up smaller hospitals. And the systems began to become powerful. And the insurance companies said, watch out, they're going to start raising prices. So the insurance companies talked to the attorneys general. And the attorney generals warned the legislatures. So they halted these acquisitions. And at the same time, the insurers were seeking higher quality with lower cost. And so in Massachusetts, Romney Care was invented. And Romney Care became the precursor for Obamacare. And Romney Care, to me, as a private practice solo physician, brought on stifling regulations. And it brought on the end of small practices. And unfortunately, it was most of these small practices that had the ethical-minded doctors and nurses. And we got swallowed up or we died. And then PHOs and IPAs were invented. And then I began work in healthcare reform, and I joined this innovator called Phil Gaziano. He's my Italian doctor for the day. And he was trying to work with insurers, like the go-between between doctors and insurance companies. And in Massachusetts, for the first time in decades, and this is the end of my intro, for the first time in decades, we lowered cost while raising quality. And Blue Cross Blue Shield of Massachusetts celebrated to no end, and they actually shared their savings with the doctors and the hospitals in Massachusetts. That was part of the plan. So I'm going to try to teach you, what does an insurance company care about? We've talked about ethics and philosophy and theology that drives us, and it should drive us, but insurance companies don't need to be driven by that. I've been there in those boardrooms. This is what they care about. They want to decrease the cost of their premiums because employers are sick of paying so much money for their employees' health care premiums. So the insurers are trying to increase the value, and by that they'll be able to lower their premiums. So value in their mind, and we need to live under this ACO system for the next decade probably. In Brandeis they said this is already slated for failure, but we need to get a foothold in naprotechnology. We need to get a foothold in this system. And so quality divided by cost equals value. So that means if you improve the quality at the same cost, you've improved the value. If you decrease the cost with the same quality, you've increased the value. Okay? Now I'm going to start to go fast. So, quality in reproductive health care, I'm going to compare restorative reproductive medicine to ART. So you see on the top line, our birth rates, as you've seen in these presentations, are about the same. IVF versus NAPRO, about the same birth rates. But look at the benefits. We have markedly reduced multiple gestation rates. Do you know how expensive a triplet pregnancy is? We have decreased maternal complication rate. We have decreased perinatal complication rates. We have decreased birth defects. I'm sorry, the lines get a little bit skewed, maybe? Yeah, the smaller arrow goes to miscarriage rate. We have, unfortunately, only been able to lower the miscarriage rate a little bit, but remember the presentations yesterday, we take all comers, all ages, whereas the IVF, they use AMH level, day 3 AMH and day 3 FSH level to screen out people that are going to lower their statistics, because 24.5% success is so much worse than 24% because they're battling with other IVF companies for the business. So they're screening out people with these AMH levels. And Dr. Phil Boyle, our colleague, has shown that it makes no difference in the outcomes of restorative reproductive medicine what somebody's AMH level is. And we've decreased low birth weight, markedly decreased low birth weight. So this is quality of NAPRO technology. Here's just an example to cite 2 points. Our twin rate, here's some studies, the NAPRO studies in the top 3 and 2 IVF studies in the bottom 3. You pay attention to the blue column and you see that our twin rate is much lower than the IVF rate. Our triplet rate is practically 0, and their triplet rate, I think, is around 6 or 8%. Another stat to put in your mind, if we had 2 twin babies, two of them from twin pregnancy versus 2 from singleton pregnancies, the cost is doubled for these babies. If you have triplets, the cost is 4-fold. So you can imagine that insurance companies wouldn't like paying 4-fold cost for the same 3 babies. Here's another statistic, and then I'll move on, just trying to show the quality point. Let's look at the second line. Prematurity rate in IVF, proven in this journal article, is less than 5%, whereas IVF, it's 30% or more. 30% is being very generous to them. There's also double the perinatal mortality, that means the death in the first year of life, and double the birth defects. Okay, now I'm going to show you something real quick. This is the way insurance companies think. Episode of care. The entire cost of managing an illness varies by the approach. For example, here's a quick example. If someone with a cough goes to the ER versus they have a cough and they go to their PCP. In the ER, you're more likely to get chest x-rays, lab work, prolonged stay, high utilization, no continuity of care. But if they go to their PCP, well-known, minimal care needed, maybe antibiotics, maybe not. Huge different cost for the same symptom. So the same outcome at less cost, you've lowered the cost, so therefore you've improved the value. When you turn that attention to infertility, a couple with infertility presenting to an IVF center, this is the way insurance companies think. The height of the bubble is the expense. And I should have put one of those squiggly lines above the $1,000 mark, because you see it goes up 12-fold from there. So the height of the bubble is the expense, the width of the bubble is the duration. I'm not going to spend a lot of time, but it's pretty cool to see how they think. Whereas in the lower bar, the couple goes to an reproductive medicine doctor, restorative reproductive medicine doctor, NAPRO doctor. And notice the height of those bubbles are much smaller. A brown bubble indicates a doctor visit. A green bubble indicates lab work. A yellow bubble indicates an ultrasound. Dark blue bubble means a hysterosalpingogram. Notice we hardly ever do those, at least in my practice. Laying down light blue bar is progesterone support of the pregnancy. And you see the light blue bar after the second round of IVF, they use progesterone. Well, they learned that from Dr. Hilgers, if you ask me. And so after 2 rounds of IVF, the couple finally achieves a pregnancy. Each round of IVF was at least $12,000. I say the going rate from what I hear in New York is $19,000. And they finally achieve, but she miscarries. That's what that little M stands for. So then they go back to the only thing that they know, which is another round of IVF. And this time she says, listen, I can't afford this. Put in 3 or 4 embryos this time. And so they end up with a triplet pregnancy, and the TR means triplet, and then the L means a loss. They either selectively reduced or lost one of those babies. And then that brings out a whole level of adverse effects in the pregnancy and increased care. And finally, they deliver twins early, and they end up in the NICU, the big orange bubble. A NICU stay, my guesstimation, is like $10,000 a day, and they might be there for many days, many, many days, usually until the time that they would be about at their due date. And then in the future, the couple again maybe is ready for another baby, and they go back to the IVF center. And along this whole path, they have not found the reason that they couldn't achieve a pregnancy, and those reasons might lead to bleeding problems, and endometrial ablation is the E, and the H is a hysterectomy down the road. And the insurance company has to pay for all of that. Whereas in the NAPRO doctor, they figure out the reason, fix it, and they achieve a pregnancy, support with progesterone, and she delivers the D 9 months later. Routine prenatal care is the same between the two. So to speak. And then later on, she says, hey, we're ready for another baby. They go back to the NAPRO doctor, preconception counseling, and make sure that they're healthy. Okay? So restorative reproductive medicine is gaining traction with the insurance companies. I have met with the 3 leading insurance companies in New York, and they are excited about what we do, but they won't cut us any slack. They say, we don't change policy for 1 doctor and 2 nurses. But they listened, and they showed up. Obamacare focuses on the cost of care, and it says we're going to make doctors and hospitals responsible for the cost of the care. That's the only way we can crimp it. And we're going to focus on managing populations, such as the infertility population, and maintain quality while trying to restrain costs, and they're very good at that. Now, acute treatments, if we treat infertility as an acute disease, Joe Stanford is the one that taught me this, if you treat it as an acute disease, you're missing the point, because these are chronic diseases, thyroid problems, pituitary problems, they're all very chronic diseases. You can't treat them as an acute disease. If you do, it's going to be more expensive. I went backwards. Okay. And they are now setting up commissions to restrain the costs. And they're trying to dissipate power. And they're these ACOs are into chronic care management. So acute treatments are expensive and don't serve us well. So the stage is set for this enlightened perspective that you've been hearing about to come into the infertility management and of other gynecological problems. And here's a quote, just out this past 6 weeks. Professor Lord Robert Winston, who is a prominent IVF specialist in the UK, who has altered IVF procedures significantly with his contributions, says that it is fundamentally wrong to treat infertility as the diagnosis. It's not a diagnosis, it's a symptom of many underlying diagnoses. It could have 50, 60, or 70 different causes. And here's an example. Is Kara here? Yes, Kara's here. This is my favorite poster presentation in 40 years of being a doctor that I've ever seen. It was at a CMA meeting. And she showed that it was cheaper and higher quality and better outcomes to fix damaged fallopian tubes than go to IVF. And if you remember back in the 1960s and 70s, the reason that they were looking towards IVF was because what are we going to do for the lady with blocked fallopian tubes? We have to do something for her. But now the ASRM, American Society for Reproductive Medicine, has changed their tunes and said it's actually better, guys, to do that. And here's where Kara Buxmuller showed us that in this poster presentation. This is a complex slide, yes. And again, the price is listed in the gray bars behind, and the success rate in the green bars. Success rate in achieving a healthy pregnancy. Those first 2 gray bars, like the Twin Towers, they should be 6 times higher than the green bars in front of them. Again, to get them on the scale, they had to fit them that way. So if you look at these 2 columns below, rows below, you'll see that 54.55, that's laparoscopic, hysteroscopic fallopian tube repair. That had the highest success rate of any mechanism on here, 54.5% achieving pregnancy, compared to, with multiple rounds of IVF, they could get up to 36.9%, and the cost of each IVF, $12,400. But the cost of this fallopian tube repair was only $2,500. What do you think an insurance company would say about that? Aha. Kara was only a second-year medical student at that time. Now she's an OBGYN resident. She figured it out for the insurance companies. One last quote from Lord Robert Winston. One of the most important issues is actually making the diagnosis and finding more effective, simpler remedies. And he went on to say, this is his quote, but most clinics are now geared up to do IVF, so they don't actually treat the underlying issue. And he says it is profit-driven, in another quote later in the article. It is profit-driven. So, infertility is due to chronic disorders. The quality will improve if we treat it as a chronic disease. Cost should be less, and this will catch the ears of the insurers and the IPAs out there, like one that we have called Physician Partners in New York. And Atul Gawande just got hired by Warren Buffett and Amazon to create a whole new health system. He is a surgeon in Boston, and this is what he says. The most expensive care, aka IVF, is not necessarily the best care. He wasn't talking about IVF, I don't mean to misquote him. He was just giving us general principles. And the best care often turns out to be the least expensive. I'm going to give you the last few quotes and then I'm done. He says it will have decreased complications and increased efficiency. So for best results, he says, we need to have health systems, and this is where I speak to the people in this audience. We need to have health systems, because for me to do it as a solo private practitioner, to do NAPRO, I go broke. Can't do it. Knights of Columbus might help a little bit here or there, or whatever. The diocese can't fund me. Healthcare is too expensive. But a health system where you become a Catholic entity, people love coming because maybe the infertility, and then maybe they come for their orthopedic problems, and their heart problems, and their gallbladder problems. So we become a magnet for the healthcare system, even though we're maybe not profitable. So, working together, we can improve value. And Blue Cross Blue Shield in Massachusetts would say you give the doctors evidence-based guidelines like Joe's trying to accomplish in the next few years. He needs funding to do that, by the way. The IRM needs funding, it's not just Joe. And then you teach the providers and you incentivize patient choices. Here's my last quote for you, I think. Cardinal Burke is like our healthcare reform advocate in the Catholic health system. And he says we need to use our goods wisely in the service of those that have grown weak. And part of using them wisely should be a sound healthcare economy. So he agrees with the insurance companies trying to save money. And we need to measure those outcomes and prove it. And yes, ethics is valuable and drives us, but patient satisfaction scores and reporting and things like that. And we need to meet the needs. One of my biggest concerns is how can the Pope Paul VI Institute train enough doctors if this catches on? The answer is they will be able to, because the insurance companies will say, we need more of these guys, where do they get trained? So then the Pope Paul VI Institute can do 2 or 3 sessions a year instead of just 1. Price, power, political agenda. Those are some of our pitfalls. Barriers to implementation, corporate struggles, lack of religious conscience protections. You've heard them, and this is almost my last slide. Potential gains. Who can gain from this? Not just the insurance companies, compounding pharmacies, we all use those. Catholic systems to foster their mission in the community and evangelize. Reimbursements, can be negotiated to be higher, and women and families benefit. And down the road, you'll have fewer breast cancers, premature deliveries, disabled children, and hysterectomies. My last slide, the culture benefits. We have authentic feminism. God bless you all. You get it. Life is a gift. The dignity of the embryo and personhood at the earliest stages. Respect for women and marriage. And husbands' respect for their wives because they get to understand all of this stuff. So now, Dr. Brehany is going to lead us in discussion and bring out your thoughts. And thank you for your endurance.